صباح الخير طلاب. Good morning. Today's lecture is about muscle diseases, myopathies. The objectives of this lecture is to recognize the existence of muscle diseases. What I mean by that is that muscle diseases are pretty much rare diseases, and they are actually misdiagnosed most of the time. They present in more or less subtle manner that evade diagnosis. So that's why we need to familiarize ourselves in order to recognize muscle diseases. The second objective is to differentiate them from other disorders, especially disorders of low motor neuron. I'll speak about that later on. And to know about the various causes of myopathy. These are quite varied, they are a lot. So we will only have some outline about these various causes. We don't need to go to the very details of them. And to know about the basic investigations of myopathy. Now, the clinical picture. What I will speak about here is the shared clinical picture between almost all myopathies. They all come with some shared pattern. So we will speak about this common presentation. Now, most myopathies come as muscle weakness. That is proximal muscle weakness most of the time. Although they can affect the cranials, but the majority of them, the main symptoms is proximal muscle weakness, so you will expect to have some weakness in the arms or the legs, difficulty in elevating the arm, or difficulty in putting clothes, putting it on the rope, or difficulty in standing from sitting position, or sitting from lying down, or going upstairs, and so on. So this is pretty much the main presentation. Usually myopathies are not very variable in presentation, and they come more or less symmetric, in a symmetric manner, most of them. So they are not episodic, and they are not asymmetric like neuromuscular junction disorders. And the majority of them, they are steadily progressive. There is no actually loss of tone or tendon reflexes. Actually, these can happen, but in a very late stage, where there is significant muscle wasting. This is very late stage. They can have low tone and loss of the reflexes. But you won't see any sensor changes or anatomic abnormalities like what you see with the neuromuscular junction, like Lambert-Eaton, or with polyneuropathies. And now you need to be aware that myopathies can affect, some of them can affect the cardiac muscle, and so they can cause cardiac failure, and they can cause also cardiac conduction abnormalities, bradycardias, various kinds of bradycardias, or even tachycardias and arrhythmias. And of course, respiratory problem is one of the bad outcomes of these disorders when it affects the respiratory muscles, and can also present with sleep apnea sometimes. So now the differential diagnosis, as I said, from the objectives, the main differential diagnosis of myopathy is actually from other causes of low motor neuron disorders. So you have neuropathy, especially polyneuropathy. Here in neuropathy, you will have reflexes loss. It's mainly distal. Weakness is mainly distal, not proximal, and it can affect the sensory nervous system. So it can present with sensory changes or autonomic changes. You don't see any of that with myopathy. Now, and then with the neuromuscular junction disorders, you will see them in a bizarre presentation. It's asymmetric and variable, as we saw with myasthenias in the last lecture. While with myopathy, they are pretty much stable, and they don't have that bizarre picture. With anterior horn cell disorders, you have early loss of reflexes, and you don't have that with myopathy. Now, the main thing is how to investigate them. Also, these investigations that I'm speaking about is the common investigation. Is the investigation common to all causes of myopathy, so they are almost irrespective of the cause. Any case of myopathy, you will send these shared uh, investigations. So you'll investigate for creatine phosphokinase. This is an intramuscular enzyme. So during any muscle destruction, it will be released into the blood and it will have high levels, like more than 300, like 100 or even higher, 1000, sorry, or even higher levels. EMG nerve conduction study will also show you a typical picture of muscle involvement. Don't need to go to the details of that, but it can discriminate between muscle and nerve involvement. I mean, the EMG nerve conduction study, electromyography, and nerve conduction study. Regarding muscle biopsy, and we send them for different staining with histobiochemistry, especially when we are suspecting, I mean, storage diseases like collagen storage disease or fat storage or protein storage diseases, like what happened with the congenital inherited metabolic disorders of muscle. So here histobiochemistry would be very important. Muscle biopsy also might help us to differentiate dystrophic from inflammatory myopathies. So CPK or CK EMG nerve conduction study and muscle biopsy is pretty much shared. We always do that for myopathies. Now electrolytes also is important. Urea electrolyte, urea creatinine, urinalysis, myoglobin. The ECG also is important to exclude cardiac conduction problems, and chest X-ray will also can show you cardiomegaly. Uh, so all of these are important. Or sometimes chest X-ray also can show you scoliosis, and that can be associated with myopathies. Now these are the general investigations. There are investigations of underlying cause. These are specific investigations, depend on the situation in which the patient is presenting. So there is a genetic metabolic screen for congenital inherited metabolic disorders, or genetic for hereditary disorders, and also counseling. So we'll send them for genetic survey or genetic screening in case you are suspecting that this myopathy is hereditary in origin. For the acquired causes, there are varied, as I said, so it depends on the setting. So if it's inflammatory, then you will send for connective tissue disorders, I mean collagen vascular screen, and so on. If it's endocrine, you will go to the relevant suspicion, electrolytes, etc. Now, regarding the causes, actually, as I said, the causes of myopathy are pretty much varied. They are extensive, and you don't need to go into the details of every myopathy, actually. So we will only familiarize ourselves with these actually disorders in order, as I said, to have a grasp about myopathy, because it comes in a subtle way. It's usually undiagnosed, unfortunately. It's pretty much late diagnosis, so you need to have high suspicion index about them. They are rare disorders, actually. So here, the causes are either hereditary or acquired. The hereditary causes can be divided into dystrophies, congenital, inherited metabolic, and channelopathies. We'll speak about I'll show the various kinds of dystrophies. Regarding congenital myopathy, usually presents early, actually at birth, and the patient will have difficulty in sucking. I mean, sucking reflexes are not good, so breastfeeding will be affected, and also you have dyspnea and cyanosis and have respiratory difficulties, and you need to be kept in incubators and so on. With the inherited metabolic disorders, these can present their spectrum of a lot of actually diseases and a lot of metabolic disturbances, a lot of causes, a lot of kinds, a lot of hereditary modes. Actually, inheritance modes are very varied. They can present as early as 4 or 3 years of age, or in the teenage, or even later actually, and mainly involve storage diseases like lipid storage or protein or glycogen storage diseases in the muscle, and there are quite a lot of them actually. Channelopathies, actually, these are an interesting group of diseases, and there are acquired causes and hereditary causes. So the channelopathies usually are more episodic. They present in episodic manner. They cause episodic weakness, and some of them can cause myotonia, and we'll speak about them. Uh, if you look at that man, you will see this is a case of actually myotonic dystrophy. So myotonic dystrophy is the most common hereditary muscle disorder in the elderly. So that's the most common one presenting in elderly. So you see here, you see the frontal baldness, you see the temporalis muscle wasting, you see the ptosis also, and the problem with myotonic dystrophy is that those people can have systemic manifestations, and systemic manifestations usually involve cardiac problem, heart failure, conduction defects, and also there is impaired glucose tolerance due to high insulin resistance, and so they can be diabetic, and also many of them, I mean, are infertile. I mean, they have impaired testicular function and sometimes even testicular atrophy. So myotonic dystrophy is pretty much a very harmful disorder, and this is in addition, of course, to the weakness that I spoken about, the proximal muscle weakness. I am not speaking about it because most of them they present with that picture also, proximal muscle weakness and the clinical features that I spoke about. Now this slide, I won't show it here, but you need to see it with the handouts. With this lecture, there are handouts. One of the handouts is a link to the timeline of Duchenne muscular dystrophies. And this is one of the most common kinds of dystrophy in the world, Duchenne and its variant, Becker muscular dystrophy, which is a kind of milder kind of Duchenne. So you need to see it in order to familiarize yourself with that disease and how long it takes and what is the problems that usually the sufferers will be troubled with. So you need to see this case is about 5 minutes and see it and familiarize yourself. You will see Gower's sign shown very well in that cases, and you'll see concentrate on the gait and how they walk and the excessive lumbar lordosis and the time trend and how they get worse by the time. And also this is another video about facioscapulohumeral muscular dystrophies. So let's see the beginning of this video.
FSHD is a disease that is severe and affects muscles. It's a crippling disorder and can be very painful at times. Typically, it's diagnosed in the teenage years, so young adults discover for the first time that they have a severe, crippling muscle disorder. FSHD, or facioscapulohumeral muscular dystrophy, is so called because it affects the face, the wing bone muscles, and the muscles of the upper arm. And that's often the way it first manifests. An inability to smile, for example, or difficulty chewing because the muscles in the face are not working properly. And then finally, it can affect the strong muscles that allow us to stand and walk, thereby forcing people into a wheelchair prematurely. It's also inherited in a dominant manner, which means that if your parent has it, you have a 50-50 chance of getting it from your parents. In addition, however, up to a third of cases are so-called spontaneous. They had no genetic history of this and it just appeared out of nowhere. Imagine the horror of discovering that your child, who's been growing up normally, has now developed a crippling muscle disorder that may put them in a wheelchair within a decade or a few decades.
I just wanted you to see this patient. Look at this picture in particular. You can see the eye opening is increased because of the facial muscle weakness, and the wasting also involved uh, with this weakness in the face, and also the mouth with the big opening of the mouth because of bilateral actually facial weaknesses. The patient can barely speak actually, uh, and you see also her shoulders how thin they are. I mean because of severe wasting. If we have, let me show you how she speaks. You see the nasal. You see that the patient cannot speak. So these are one of the survivors of facioscapulohumeral, and you see the difficulty in speech, great difficulty in speech. So it affects the muscles of the face, and even sometimes muscle of the pharynx, and also the upper limbs. So and the scapulae, of course. So that's why it's called facioscapulohumeral disease. And you see here, it presents in all the ages than those of Duchenne muscular dystrophy. Girdle, this presents usually in the teenage, and you see that the problem from its name is limb girdle, so it affects the shoulder girdle and the pelvic girdle. And it's also a degenerative disorder. All dystrophies are degenerative disorders. All of them are long lasting. All of them, there is no medication for them. So they are relentless disorders, slowly progressive over years. And they cause a lot of handicap to the patients actually. This is a case of oculopharyngeal. You see the ocular muscles, you see the eyelids, there is ptosis, and not only ptosis, the lower lids also are weak due to some facial weakness, and also you have squint, which is due to intraocular muscle weakness. Of course, the patient is expected to have diplopia also, and this patient also have difficulty in swallowing and difficulty in actually speaking. He will have nasal speech with difficulty in swallowing and frequent aspirations, and that's why it's called oculopharyngeal muscle dystrophy. Yeah, this sketch will show you the different time at which the onset of symptoms happen with different dystrophies, muscular dystrophies. So you see the earliest is Duchenne and Becker types, then comes emeridriefus and limb girdle was in the middle, and then come facioscapulohumeral and oculopharyngeal. They are at all the ages. Now, with this slide, you see the differential pattern of initial muscle weakness in myotonic dystrophy. Sorry, in muscle dystrophy. So you see these are the types. You see here in Duchenne muscular dystrophy, the muscle involvement is proximal and all of it is proximal. It's like limb girdle, while in emeridriefus it's proximal in the upper limb, distal in the lower limb. In congenital muscular dystrophy, it involves all the body actually, while with facioscapulohumeral, it's the distribution we've spoken about, and the same with oculopharyngeal muscle dystrophy. So now we spoke about muscle dystrophies and congenital muscle and hereditary metabolic disorder. So we come then to the next disorder, which are channelopathies, and we speak about them. paralysis and actually to channelopathies. Now, with channelopathies are disorders of the muscle membrane and in channels present in the muscle membrane and protein present in the muscle membrane. So the main channelopathy is actually myotonia, possibly congenita, and the main form of it is Becker's myotonia congenita. There is another hypertrophic form which is called Thompson's, myotonia congenita. So with myotonia, actually, I didn't put it here on the slide, but in myotonia, what you see is difficulty in relaxation of the muscle. So when he shakes your hand, he cannot leave his hand. He will always remain gripping your hand. Or if he becomes amused and he closes his eyes, forcibly he cannot open his eyes. So there's difficulty in relaxation due to difficulty in repolarization of the muscle. So this is a problem in the muscle membrane channels, and it usually becomes better if the patient starts to do exercises. It becomes actually worse if you rest. You take rest after exercise, it becomes worse. So it is warmed. When you warm up, it goes and disappears. So this is the hallmark of myotonia congenita. While paramyotonia congenita allows like myotonia, but it occurs in the opposite way. It occurs with exercise and with cold. So it is in the opposite way. Usually treatments are treatments like phenytoins or treatments that sometimes we give to arrhythmias in the heart. So they are membrane stabilizers. And there are a lot of treatments actually for it. Now you are not, asked to remember these treatments. Now we come to periodic paralysis. Periodic paralysis actually is, I see them more common. There are acquired types and there are hereditary types. You have two types. You have hypokalemic periodic paralysis and you have hyperkalemic one. Now the hypokalemic one is the principal one really. With the hypokalemic periodic paralysis, you can have paralysis up to 2, 3, or 4 days, or even up to 5 days. A patient comes to you with weakness in upper limbs and lower limbs. When you examine him, he doesn't have any difficulty. Any decrease in tone or an increase in tone. No changes in tone, muscle tone, and no changes in the tendon reflexes. So the temporal reflexes are normal. Muscle tone is normal. Babinski is normal, so neurological investigation appears normal apart from the generalized weakness that he has. It doesn't affect the cranials and it continues for several days and then it will reverse and come back to normal by itself actually, or by treatment in case there is severe hypokalemia. Usually the hypokalemia is not very severe in the hereditary. Is not very severe in the hereditary form. It's actually severe in the acquired form. So if you have acquired form like severe diarrhea, for example, or adrenal diseases, there where it will be severe, very severe actually. And like if you have Cushing disorder, for example, or Crohn's disease or something like that, hyperaldosteronism, so you'll have hypokalemia. So with hypokalemia, actually, you will have retention of sodium and secretion of potassium. So in that way we have severe hypokalemia, adrenal problem or GI tract problems or even renal problems, some of the renal diseases. So if you have hypokalemia due to acquired causes, then the actual potassium will tend to be lower than 3.5 milliequivalent per deciliter, which is the lower limit for potassium. While in hereditary periodic paralysis, you won't see it so low, you will see it a little bit low or actually lower normal. So what are the triggers of these periodic paralysis? Periodic paralysis, truly it will come back to normal, but it will come back again after 3 months or 4 months, or possibly at a lower rate than that, and it's usually familial. and the problem is due to a sodium and sodium or calcium channel, and the triggerers are heavy carbohydrate meals and also high salt diet. And the reasons are very clear. In heavy carbohydrate meals, hyperinsulinemia will happen, and the hyperinsulinemia will cause potassium shifts intracellularly. With increasing salt, you will increase the sodium in the body. So the body will get rid of potassium in order to keep the positive charge, and so you'll have hypokalemia. So the treatment is the reverse of those. You will have a diet that is similar to diabetic hypertensive diet, which is low sugar and low salt diet, but rich in potassium. And sometimes, if it is very severe and the attacks come frequently, then we might use acetazolamide or spironolactone as a prophylactic measure. So this is pretty much for periodic paralysis. Many times periodic paralysis can be thought of as hysterical. People, you see them in young patients, and so you think they are hysterical, but they are actually not hysterical. Now, the hyperkalemic variant only lasts for a few hours, for example, up to 6 hours, usually less. So it's not much of a problem, really. And it's due to problems in the sodium channel. And it might occur after a potassium rich meal. So the treatment is usually with low potassium diet, and usually it reverses by itself within a few hours. Now, the acquired causes. So we finished now uh, speaking about the hereditary causes. Most of them are rare causes. And actually, in my experience, I saw periodic paralysis is the main one, and I think even those periodic paralysis are mainly acquired. Now, acquired causes are the most common causes of myopathy, and those are the ones that you can do something for. But mainly, the acquired myopathies will present within the disease that is causing them. So it's context related. So, for example, inflammatory disorders, it will present with, in an inflammatory disorder setting and like a connective tissue disorder setting. So you have polymyositis, dermatomyositis, and with endocrine and metabolic disorder, you will have pretty much the clinical signs and features of the underlying endocrine problem, whether it's hypothyroidism, hyper, or resistant disease, or Crohn's or Cushing's. And also toxic myopathy, like what happens with alcoholism or vitamin E, or with organophosphates or snake venoms. So it depends mainly on the underlying condition. Uh, Unlike hereditary myopathies, which might strike you like that alone, and then you will know that there is a hereditary family of disorder. So with drugs also, these are the list of drugs which can cause myopathies. And interestingly, myopathies can be paraneoplastic, especially even polymyositis can be paraneoplastic. So one should always bear that in mind. Now, one of the things that I want to orient you to is rhabdomyolysis. Now, rhabdomyolysis is a life-threatening condition. In rhabdomyolysis, there is severe destruction of muscle fibers and the release of myoglobin into the blood, as you are seeing here. It's like it's shot with an arrow, actually. Uh, so there is the muscle have hit hard, and it will give myoglobin into the blood, and then myoglobin will go into the kidney, and you see as if the kidney is bleeding because the urine actually will be reddish brown urine due to myoglobinuria. Now, myoglobin can cause renal failure and can lead to death because of renal failure and associated hyperkalemia. So it's a very dangerous condition. And usually, what causes myopathy, myoglobinuria, is a stressful condition. It's usually a stressful condition like severe injury, car injuries, or burn, or severe illnesses like sometimes even strokes, or sometimes even malignancy, diabetic ketoacidosis. Here will here these are the causes of rhabdomyolysis. So you'll have muscle injuries, medications, illicit drugs, cocaine, alcohol, amphetamines, statins. Sometimes statins can cause severe rhabdomyolysis. One should always have that into consideration. While here, the muscle injury, have the trauma, the burns, the electrocution, of course, or sometimes diving in the sea will cause crush, muscle crush. And it will cause severe rhabdomyolysis. Some kind of infections also can cause that, and like viral infection actually can cause that. And increased muscle injury like sports, seizures, status asthmaticus, infection, inflammatory myopathies, hyperthermia and hypothermia, all of those can cause rhabdomyolysis. Here, this is also within the acquired causes. And here we are speaking, of course, it's clear that we will speak about dermatomyositis, polymyositis. And here you see the violaceous hue, the periorbital edema, and the V sign, the Scholl sign, and the Gaucher nodules. Once you see that, then you are with dermatomyositis, and you can have associated polymyositis. Now, polymyositis, it will present as its name, polymyositis, so it will affect most of the muscles. It can affect the cranial nerves, of course, and affects usually the upper and lower limb, mainly proximal, and usually it comes with muscle pain and muscle tenderness. You might have fever, and you have elevated CPKs, of course, and a typical EMG nerve conduction study of muscle disease, and sometimes very strange, finding on EMG nerve conduction study. Sometimes it doesn't have all of these features, some of these features, so it can present a difficulty in diagnosis. The main thing in polymyositis is that it is treatable. You can treat it with steroids and immunosuppressants as you treat many of the connective tissue disorders. But it is life-threatening in some sense that it's associated with vasculitis if there is dermatomyositis. So you need to check the heart and make sure of it. And also, one of the danger things about it is that it can be paraneoplastic and can precede neoplasm actually by many years. So you should search for a malignancy when you see polymyositis. So okay, here we reach to the last slide of the last lecture. That's the end of it. So I hope you guys had nice times reading my lectures, and I hope that you could fathom them very well. I know that these sites are not easy to fathomize, but I hope that you did that. My formative will start at this Friday. It will be in an MCQ form, about 2 MCQs for each lecture. I will make an assignment for you for this lecture. So I will leave you questions after that thank you slide. You will see them, so you can pick one question and send me the assignment. I will make the assignment. I will tell you what to do. I hope you had nice times, and I wish you the best, really. And I leave you with the questions, and see you next year.